So that was easy. We're all done, right? Not quite. I want to thank the folks who came to give public comments and thank the panel, obviously, for sticking with the data as it comes out. It's very hard to figure out always how to package so much evidence in a way that can be purposeful and value added on the day. But I do know that the panel has done a lot of work reviewing the draft report and everything else. And again, I want to thank Dan and Jeff. We have a whole hour, which is going to be fantastic, to discuss the evidence report in light of the votes that the panel will be taking starting around 1:15. What I want to emphasize is that we are going to engage now with the policy roundtable twice today. We're going to do it now before the votes for a phase in which we hope that the panel and the roundtable can talk about the evidence, aspects about the evidence and how it will be viewed by them when they take their votes. Because after the votes are done, we have the roundtable join us again for the conversation more forward-looking about how we apply the evidence in the healthcare system. So if there are certain questions that you may have that are just burning around the price of the drug or other things, try to think about whether it's a question about the evidence for the voting or for the roundtable that we'll be doing later. And let me introduce the roundtable that's now joined us. Do I have a way to bring up this slide to the screen? That's okay. Yes, thanks. So, lined up over there, we have the following panelists who are joining us. I'm just going to introduce you and maybe just raise your hand so everybody knows who you are. Sylvia Carlisle, who is the Managing Medical Director at Anthem Blue Cross. Ryan Clary, he's the Executive Director of the National Viral Hepatitis Roundtable. Rena Fox, she is Professor of Clinical Medicine in the Division of General Internal Medicine at UCSF. Todd Frederick, sorry I didn't get a chance to shake your hand. I knew you were able to come for the afternoon. Thank you. He is a transplant hepatologist and the Fellowship Director of Transplant Hepatology in the Division of Hepatology at California Pacific Medical Center. Amandeep Sahota is a transplant hepatologist also and Southern California Permanente Medical Group Regional Hepatitis C Champion. And that means that she's in charge of helping to organize their overall approach to the treatment of hepatitis C patients. And Robert Snedeker. Now, he's a late addition to the roundtable, and I'd like to thank him for participating. As the CTAF panel, we've had, again, new members. We have some old members. The idea of having a policy roundtable is relatively new for CTAF, and it just seemed clear to us relatively late in the game that it would be vitally important to try to have the perspective of manufacturers be part of this conversation. So we put out an invitation to the two manufacturers who manufacture Cimeprevir and Sivosbuvir. I'm sorry, is it doctor or not? Snedeker? Bob, just Bob. Bob is with Janssen, which is the company that makes Cimeprevir, and Gilead declined our invitation to participate on the roundtable. And we also have John Yao, who is the Senior Medical Director for Blue Shield of California. All right, so again, some of the issues for some of the roundtable will be more germane in the latter part of the afternoon after the voting. But I wanted to come back perhaps, and we can even kick off with Rita's question if you'd like to reframe it, because now we have a full panel with which I think we can delve into both clinical expertise, some of the systems issues, but primarily looking at the evidence. And sorry, Rita, before you restate that, for the panel, can you all locate your Select Tables handout? It is a 17-page compendium that we put together for you of the key tables from the full report, organized in a way that we hope will be most helpful to you when you do the votes. So if you have that, the other document that you should think of twinning with it in your mind is the printed out copy of the voting slides. So you all have both of these handouts, including the round table. Right, Karen? They have it too, the round table? Yes. Great. And the reason I want to suggest you look at these together is because as you go through the voting slides, on each voting slide, the first one is slide 5, it says see key tables pages 3, 4, and 5. So for each voting question, we've tried to show you where on the tables handout you should go for the key tables that should help you in your decision making around that voting question. As you reflect, as this is a working lunch, as you get a chance to look at the voting questions and the tables, this is your opportunity again to ask for clarifying information from Dr. Tice, from Dan Ohlendorf, or from members of the policy roundtable around the evidence that you're going to be looking at for these votes. All right. Any questions about the handouts or the layout for the votes, Dan? Oh, not about that? Go ahead. What else? Did you have another question? Sure, go ahead. Oh, yeah, use the mic. You have to turn.
Yeah. Whether the results on which we base our decisions today, that is the studies, are achievable outside the investigational situation. And this is sort of directed to Dr. Fox. This is complicated medical care, obviously. I doubt whether your average primary care physician is going to be treating Hep C. Maybe I'm wrong. But are these results that Jeff quoted today pretty much generally available with the proper number of, say, hepatologists, infectious disease experts, and so on? Or is this only available in a fairly rarefied special centers? Dr. Fox, could you comment on that?
Let me just clarify, you're asking, is the information available, or is the expert care available?
Is the expert care available that would reflect the studies that have been quoted today?
Up until now, with interferon part of hepatitis C care and fibrosis staging part of hepatitis C care, I think that for the most part, treatment of hepatitis C has been kept with specialists and maybe a few non-specialists. There's definitely been efforts to help non-specialists care for hepatitis C patients in rural areas and areas that don't have good access to hepatologists or transplant hepatologists. And those have been successful, but they're very small. I think going forward, the idea of non-interferon-based treatment and less need for fibrosis staging in the future will open up the possibility of non-specialists treating hepatitis C patients all the way through, from diagnosis through treatment. I don't know that we're there today. Right now, these drugs are, number one, so expensive. Number two, there's still many different factors in decision-making. But I think in the hopefully near future, non-specialists will be part of the treating possibilities for patients, which would be great, and would increase access to care. Because one of the many reasons that we have a low number of patients treated is access to specialists and areas where they're comfortable with hepatitis C treatment.
Thank you.
Mm-hmm. So one more piece of housekeeping, before we do get back to questions from the panel. I should have done this earlier. Obviously, many of you are employed by healthcare organizations, but could we just go down the line, since we'll be asking you questions about the evidence, and can you just let us know if you have any financial conflicts of interest in this area, you personally or your organization? Amandeep?
No conflict of interest. I work for Kaiser.
I am an advisor and consultant for Gilead, and I do clinical trials for Gilead.
No conflicts of interest. I work at UCSF, and I'm also employed by the Central Office of the Veterans Affairs Administration.
I have no personal conflicts of interest. My organization, we're a patient advocacy organization, is funded by several pharmaceutical companies, among other funders.
All right, thank you.
I'm an employee of Anthem Blue Cross of California.
I have no conflict of interest other than holding a few shares, just pittance, in terms of Abbott and Gilead shares.
I have stock in J&J.
All right, good. And we've got Dan and Jeff at the end of the table. Okay, so back to our business over working lunch. Rita, would you like to repose your question? Or I think it would be helpful for the whole panel to hear the answer from folks over there.
Thanks. So I was trying to get more information on the inputs to the model because they so determine the output we get, and particularly because we're being asked to, model for many years based on trials that went 12 to 24 weeks. And, and so what I'm interested in particular, is how the population of sort of asymptomatic persons that we would presumably be looking at based on a big hepatitis C screening campaign, on baby boomers, compares to the patients that were in trials, because my assumption is, for like most things, it's the most sick people that are going to benefit more, and I might personally have a higher bar for starting treatments in people that feel perfectly well, because you have to assume a lot of things to see a benefit in someone who feels perfectly well, that in 40 years you will have prevented a death from hepatocellular cancer, and because it means that they wouldn't have died of anything else and that they would have been the person that got hepatocellular cancer. So I'm trying to get a better idea for what those numbers would be. If we took the whole population now in the US and how many had hepatitis C, how many of those would actually die of hepatocellular cancer? And then how many of those deaths would we prevent if everybody was screened and then was able to get one of the treatments that we're looking at today? Because that seems like the big, and to me, I wasn't able to get a good feeling for that number looking at all the data. And of course, that's the question, would I personally want to go get hep C screening when I feel perfectly well?
Yes, please, feel free.
I think in terms of the number of people with hepatitis C who may go on to develop hepatocellular carcinoma, let's estimate that it's 1%. At the time, because we're talking about people who are symptomatic or asymptomatic, most patients before they have very advanced liver disease are asymptomatic, similar to hypertension, right? And I think of this similar to hypertension, that we're treating hypertensive patients to prevent stroke. How many of those patients will go on to get a stroke if we don't treat their hypertension? And it's similar in that we don't know which of these patients may or may not go on to develop advanced liver disease if we don't know what their trajectory has been. But the difference here being, of course, the cost. The cost of sofosbuvir is much different than the cost of hydrochlorothiazide. But I think in terms of number of patients who we could predict from all hep C patients, symptomatic or not, it would be around 1%. Would you agree, Mike, at hepatocellular carcinoma? And in terms of the patients in trials, actually, I would say mostly asymptomatic patients are in trials, because the symptomatic patients who have decompensated cirrhosis are not included in these trials.
That helps, although I think it's a little different from hypertension because we have a lot more long-term data on hypertension. I mean, this is clearly a very, it's 1% of all people with infection with hepatitis C, but we don't know, how many deaths would, 1 out of 100 is already small, how many of those would not have died if they had taken, how many of that 1% deaths would have been prevented if they had taken this treatment?
I agree in that symptoms don't enter into it much in terms of deciding when or who to treat for hepatitis. And I counsel my patients when they do have symptoms that I'm not guaranteeing that eradicating virus is going to improve their symptoms, actually. if it does, that's a bonus. But the real goal is, we've been staging patients to predict who is likely to advance to cirrhosis, and then the complications that ensue with decompensation, liver failure, liver cancer, liver transplant. And so the goal for the last 20 years of hepatitis C therapy has been finding the patients who have progression based on interval staging or even one-time staging, showing documentation of a significant degree of fibrosis, treating those largely because of the toxicity of the treatment. We would leave patients with less advanced disease alone and say, treatment is not indicated at this time. And the trials, by and large, represent kind of the earlier stages of disease because of restrictions that are placed on getting into trials. Generally have to have compensated disease, platelet counts in certain ranges, bilirubins in certain ranges, and these inclusion and exclusion criteria become very strict, weeding out anybody who may be symptomatic or advancing. So I think the trial representation is, these are a pretty motivated and compliant group, which is a little different than our general population that are infected, but I don't think they represent a sicker group. And then I think in terms of the benefit of hepatitis C therapy, there are good observational studies, and I believe they were included in the background information for these reports, about the good you can do for particularly cirrhotic patients, but also all patients. If you eradicate virus, there are benefits in terms of survival, certainly benefits in terms of liver-related complications and deaths. Some of that's from the VA database, and some is from other smaller series, primarily with cirrhotic patients. But there's clear benefits in my mind, even if these are observational. Just my clinical experience of eradicating virus versus not eradicating virus makes a big difference in prognosis and outcomes for patients.
Yes, Michael.
Could you talk a little bit more about the nature of that data in the observational trial?
Yeah, Rena, I don't know if you know this data. Lisa Bacchus, I think is her name, through the VA put together observational data on genotypes 1, 2, and 3 patients, all comers, patients who had detectable virus and then subsequently undetectable virus, and looked at the differences in terms of those who eradicated virus and those who didn't, and modeled those for various complications, liver cancer, liver-related deaths, and cirrhosis, or actually in general survival, and found statistically significant improved outcomes in the patients who were treated and eradicated virus. And then there are several smaller series that have looked at patients with cirrhosis at baseline, treated, and then 8 to 10 year timelines for survival and lack of decompensation, and the Kaplan-Meier curves separate very, very prominently.
Is there any reason to believe that these new antivirals wouldn't show the same thing? Because I assume this is old data from the
Yeah, all of
previous
this
treatment.
is I believe it's all pre-protease inhibitor data, and in my mind, no, there's no reason that eradicating virus with directly acting antivirals would have any difference. And with these drugs, we have potential access to a much larger group of patients in desperate need because of the lack of interferon. That's where we've been limited, is we have large groups of patients, at least in a transplant center, where we just basically watch and support until either transplant or death. And now we have a potential, although off-label at this time, to intervene in those patients as well.
Other questions? Mary.
For Dr. Tice and then Dr. Sahota to comment on it. So in looking at the network analysis, we see the numbers on the SVR12 comparing certain regimens against PR. But the question we have to decide is these new regimens compared to the first generation And we don't have direct comparisons of those. If we look at the numbers, we see a little bit of overlap, but, differences like, 74% to 84%. Is there anything you can tell us, either from the network analysis or from your other knowledge of this, about how much of a difference in an SVR12 is a significant difference? And you can speak to statistical significance, and if you want to speak to clinical significance too, that would be great.
I would have to. I mean, I think a 10% difference is going to be statistically significant. I would have to go back and run those comparisons, though, to be sure. The bigger issue is that we had to make some guesses. We filled in some data for some of the interventions because we really didn't have control groups for some of the trials that we included. So there's increased uncertainty that isn't reflected in the statistics that I would get out of that. I think a 10% difference is, I bow to the clinical community here, but a 10% difference in SVR, a 10% difference in curing this, I think is clinically important as well. I think most people would agree with that. But I'll let our clinical experts comment a little bit more on that.
So in regards to the SVR, I mean, 10% sounds good to me, but I think from a clinician point of view, the side effects profile in regards with PR or the tenofovir combination, we are talking about patient pill burden, taking pills every 8 hours with fat, all cumbersome combination, drug interactions, multiple side effects. I think that is also we have to take that in consideration, that we're not just talking about the SVR and the long-term outcomes, but the short-term effectiveness of the treatment, also how tolerable the side effects of the treatment is.
Trying to keep my eyes on both sides of the table. Who else? Oh, Ryan, did you have something to say?
I just wanted to elaborate a little bit so I'm not a physician. I'm from the patient advocacy perspective. I'll be honest, I'm a little confused why the body's even considering the older DAA regimen. That's not really considered standard of care. We have new AASLD, IDSA guidelines that is considered standard of care by a lot of folks. My understanding is that the older DAA regimens aren't even being prescribed very much. And so from a patient point of view, just to follow up, we're aggressively trying to get out and screen folks. The Gilead ad is one of those reasons. We changed the U.S. Preventive Services Task Force testing recommendations, who put their stamp on testing everybody at risk in a one-time test, everybody born between 1945 and 1965, precisely because it's important that people know their status. If nothing else, people can be counseled around alcohol use and lifestyle change. If I had hepatitis C, I would want to know. I would also want to have an incentive to test, which would be that I would have access to the most effective, safest regimens possible. And so that's really, from patient advocacy point of view, that's what we're looking. We now have regimens that have far fewer side effects, that are far more tolerable, that have a much higher cure rate, and we have more in the pipeline. And we feel like the baseline is sort of where we're at now and where we're moving forward, and not where we were in 2011.
I'm sure that's a topic we'll return to in the later afternoon roundtable. Let me try to keep the questions coming predominantly from the panel, because we will have a chance to comment on broader issues like that, definitely. I want to be sensitive. Doug, and then, or Alex was first. Go ahead, Alex.
Panel. I'm not sure if this is the appropriate point for this question. I'm wondering how the questions were formulated, and whether I was particularly interested in why there wasn't a division between patients who had more advanced disease and less advanced disease.
Well, we talked about it within our research team. Jeff, you probably, in terms of presenting the effectiveness and the harms data, you're wondering why we didn't subdivide it by degree of liver dysfunction. Alex, is that right? All right, Jeff.
Thanks. So we primarily divided things up in part along the lines of the treatment guidelines that are recommended, and in part because most of the trials were designed based on prior treatment versus treatment naive and genotype, and not based on degree of cirrhosis subtype. And in most of the studies, as was alluded to, the patients were relatively healthy, so the proportion of patients with cirrhosis or even F3, F4 fibrosis was relatively small, up to about 20% in most of the trials. There are a few exceptions to that. So it would, we would have been parsing things. We would have many more categories and really small numbers, and we just decided we couldn't go there and felt that it would be more appropriate to talk about that from a policy perspective about who to treat. If we do think the regimen is effective, then who should we target initially? How should policy be set up to encourage the best application of the evidence?
I guess this is more for the clinicians about treatment of hepatitis C and whether you target your treatments. I've heard some implications that you do based on the severity of fibrosis and how you screen for that currently.
So, patient with hepatitis C, obviously there are different ways of getting information. One is obvious if the patient is ready for the treatment, that's very important. Number two is how their labs are looking like, their clinical situation, their physical examination, their laboratory findings, imaging, biopsy. So all these considerations are kept in mind before we decide whether the patient is an optimal candidate for treatment. Not.
John?
Yeah, if I may take a stab at answering that question as well. I think hepatologists in general, and please correct me if I'm wrong, but hepatologists in general actually have been warehousing patients in the last several years in anticipation of the newer DAAs with better outcomes and no need for combination with interferon-based regimens, side effects, and so on and so forth. So to answer your question, I think directly and indirectly, that has been done in terms of some kind of prioritization, in terms of warehousing. And I know from speaking to hepatologists that many of them feel that it is good treatment principle, for instance, to hold off some of the F1, F2s, in terms of any therapy while waiting for, more promising treatment to come down the pike. So I can say to that, in terms of screening, of course, in terms of assessing the degree of fibrosis, of course, you have the gold standard of liver biopsy, which is, an invasive procedure, albeit not a major procedure, but still invasive and certainly has potential complications. But then there are newer imaging devices now with elastography. I won't mention brand names of these machines, but there are two major machines that are commercially available that uses non-invasive ultrasound-related elastography technology to assess the stiffness of the fibrosis, and hence gives you a relatively correlative score of F3, F4 versus F1, F2. The limitation of that non-invasive screening is that the sensitivity is pretty good, actually. The area under the ROC curve is actually 0.94, and this translates to a sensitivity of almost 90% for higher grade fibrosis, primarily F4, maybe F3 also relatively high, but then it drops somewhat precipitously when you go down to F2 and F1, down to maybe 80, 70%.
Doug?
Okay, Alex asked the question that I was planning to ask, but I have a related question I want to ask, which is related to the issue of warehousing and this issue that, and my specific question is, what's the price to be paid by waiting? So it sounds like that's being done clinically, and I'm interested in how clinicians have made that decision about who's appropriate to be warehoused or not warehoused, I guess is the opposite of that. And specifically, I'm interested in your impression of the way the analysis was done, the economic analysis, which was this last color figure in our handouts, which was to take high-risk advanced liver disease and do an economic assessment of that. And I guess what's bothered me about this all along is that an SVR in someone who's at very high risk, has cirrhosis, and is very likely to develop something bad in the next few years is quite different than an SVR in a younger, healthier person who might go decades before actually having a liver event. And so my question from a clinician is, what's the price to be paid by waiting, and are there individuals who will develop overt disease despite your best efforts to monitor them or to follow them for the appropriate time to give them highly active treatment and highly expensive treatment?
Doug, that is such a central question for what we're going to do after the votes. I wonder, could you focus again on what you might want them to comment on in terms of the evidence about the budget impact? Because I think that would be...
I guess the evidence question really is, I guess for Dan also, just to clarify how you defined high-risk patients in this last little analysis that was done to us. And again, from a clinician standpoint, I'd be interested in not only knowing the costs, but the number of events averted in that risk, using that technique as opposed to treating everybody straight up.
So, in terms of the increased level of risk, so we did assume that patients with higher levels of fibrosis would constitute our advanced liver disease cohort. We also assumed, based on data from some of the same observational studies that were discussed, that the rate of liver-related complications, downstream liver-related complications, would be about twice what it would be in the overall population. So, so that's the baseline rate. And then we assumed, again, as with the overall population, based on those observational studies, that achieving SVR would reduce the rate of those complications by about 80%. So in terms of number of liver-related events averted, that's actually presented in the detailed tables. It is only presented for the overall population, but it's certainly feasible for us to generate those numbers on a per 1,000 basis as well.
But if I understand, wasn't that number of events averted was in all populations, not just in the high-risk population, right? So I guess the question is, how many of that overall number of events averted could you still avert if you just waited and selected the high-risk population?
That's something that we could potentially analyze, yes.
Dan had a question.
We're going to be asked to make a value judgment or vote on the value. Seems to me the elephant in the room is the tremendous cost of these drugs. And I guess my question would be directed to Mr. Snedeker, which would be, how is this price point determined? And with all of the other similar drugs coming on the market, can we expect the competition to drive that down so that what we say today about value might be quite different a year from now?
I feel like I'm a judge. I'll allow the question. Step away from the bar.
Yeah,
we're going to focus on, I'm sure, how to put the packages together later. But I think I guess the key question is specific to the value voting. You'd like to know whether the price, at least in one person's opinion, is likely to vary significantly coming over the next 6 to 12 months. Bob?
Yeah, I knew I had a target on my back walking in here, so I was fully prepared. But, you know, I'd love to be able to answer your question directly, but I don't do the pricing. You know, we don't even know how they do the pricing. You know, the drug's approved, and as soon as it's ready for the market, a price is delivered. And I wish I could give you more, and I'm not hiding anything. I just don't know. The other question, however, I think is very interesting, is what is going to be the impact of the newer products coming to the marketplace. And I'm not so sure that we're going to see any really deep reductions in price. That's just my assessment of marketplace dynamics over 30-odd years. So I think that this is going to be a continued discussion over the years.
Paul?
Yeah, I think for many of the questions where patients are interferon eligible, we're asked to compare the value to the telaprevir plus PR combination, which to me implies that that is a reasonable value, that compared to other care, the telaprevir is a reasonable value. So I'm just curious, would people agree with that? That is a good value, that's the standard, this is, a good value based on the data?
I have a parallel comment that doesn't answer your question directly. But But my comment is currently 25% of the insureds have Medi-Cal. Those individuals already have access problems based on the fact that Medi-Cal radically underpays for the cost of care. And so if you assume that the cost, however we want to define it, is $50 PMPM, can Medi-Cal afford for the, most Medi-Cal managed care plans in California get around $125 a month PMPM, not counting this. So when you think of the reason we need to be prudent is large clients, sophisticated consumers will suck up $50 PMPM on their premium. Will individuals purchasing insurance, will Medicaid be able to absorb $50 PMPM given what they already pay? And what's the impact, and how do we prevent from further creating two healthcare systems, which actually we already have? And so I think that it's how do we as a community, because we can create wonderful insurance for me personally, but this is a public health issue. And so we really have to think about not only what is my employer willing to pay for me, what is the taxpayer willing to pay for someone else. And we don't have a culture of insurance. There are plenty of folks who will be glad to pay whatever premium we charge them so they can get their $150,000 of care. But do they understand the importance of subsidizing someone else's $150,000 worth of care as a public health issue? Whatever the actual average wholesale price, average retail price, whatever it turns out to be, it's not going to be hydrochlorothiazide price. It's going to be probably whatever the number is, whatever's the manufacturer, so that you don't feel like you're the only person with the bullseye. Whatever it's going to be is probably going to be substantial. And how do we as a community, not only as, purchasers, taxpayers, what about folks in the prison system? What about folks coming out of the prison system?
All right, Sylvia. We've got a tiger by the tail, and we will definitely get to the breadth of your questions after the votes. So I want to let Paul, the focus of his question was really on the appropriateness of using telaprevir as a clinical and financial benchmark with which to judge value of these newer regimens, correct? So maybe we can ask I'll probably start with the clinical experts and then run the table.
So the prospect of using telaprevir or boceprevir now in light of what we have is very difficult. I would not wish it upon anybody in terms of the toxicity that we saw patients go through, having nothing better at the time. Now what we have with the two new agents is a very large leap forward, and we're looking at even larger leaps just at the end of the calendar year. So, but at the time, if you had a cirrhotic patient who, or even an F3 who needed treatment, and you used telaprevir or boceprevir, and you attained a sustained virologic response, I think that's a huge value for the patient, for society. You're averting, hopefully, decompensation, very expensive hospitalizations, and potentially a very expensive death or $500,000 transplant with long-term care there. So,
that answer your question, Paul? Ish. I will state that the field is moving incredibly rapidly. Everybody recognizes that. So all the published state-of-the-art guidelines from late 2012 were with telaprevir and boceprevir as the new standard of care. So obviously things are turning over very quickly. We do know that in other nations that are starting to look at the effectiveness and value of these new drugs, they are, at least England, Canada, and Australia are going to be comparing them to telaprevir and boceprevir as an acceptable prior standard. Again, whether that's viewed as clinically up to where we are today, that's part of the tension that we face in a very rapidly innovative kind of field. Looks like, okay, maybe, well, John, go ahead real quickly, and then I'll see if there are other questions.
Just real quick comment. I think that question is better posed in the perspective of an interferon-based regimen in genotype 1. But for genotype 1 that is not interferon eligible, then I think it's totally out of discussion, I think, clinically.
Yeah. Let me invite the panel to, again, just take a look at the voting questions. One of the things that we decided to do because of the press of time and the number of possible comparisons that we could have had you vote on was to make some what we call stipulations. That means that we looked at the evidence in the tables and our understanding of the findings from the network meta-analysis and other input, and we thought that you would feel comfortable with certain stipulations without having a full vote on it. I would love for you to look through again, the voting questions. They start on slide 5 in the slide handout. And as you look through, if you see any of these questions that you would like to ask about the evidence now, before we get into the body of the voting process, that would be a great opportunity, because we've got Jeff, we've got Dan, we've got the round table. So if you have a question either about the stipulations or any of the others as it relates to the adequacy of the evidence or anything else, this is the perfect time to do that. Yes, Christine.
So on slide 8, it says stipulate that the evidence is inadequate to distinguish between the clinical effectiveness of CTAF, which is what I'll call it because I can't pronounce the other, plus PR, and SMV plus PR. So one of the things that's interesting about this is that the SMV is not eligible to be used without interferon, and the CTAF potentially is. Setting that aside, is there a difference between the effectiveness of the two drugs?
Like perhaps the clinical experts to comment on, or why don't we start with Jeff, and then we'll circle back to the clinical experts. So Jeff, is that a fair take on?
Okay. So, I mean, the most important point to take away from that is that when we're talking about that, we're talking about Cimeprevir plus PR in patients who do not carry that mutation, so don't carry the Q80K mutation. So in those who carry the Q80K mutation, Sofosbuvir, I don't remember whether we stipulated it, but I think it would be stipulated that it's likely to be more effective, at least in the SVR. But otherwise, the data suggests they are equivalent in those who do not carry the Q80K. Using the network meta-analysis with a bunch of extrapolations, and essentially it comes from the fact that the absolute gain in SVR for Cimeprevir compared to PR was about the same as that of Sofosbuvir plus PR versus PR when those comparisons were made. And some would argue we biased against Sofosbuvir in the way we assumed the response rate in the PR group in studies that did not have PR. That was one of the important comments received to the draft. But we thought, given the lack of data and the uncertainty, it was appropriate.
That actually probably good. Rena, go ahead, follow up if you like.
I was just going to add that comparing Cimeprevir pegylated interferon ribavirin in genotype 1 interferon eligibles to Sofosbuvir pegylated interferon ribavirin. So if we say that roughly the SVRs look equivalent, the other things just to remember are that we're talking about the difference between a 12-week course and a 24 or 48-week course. So all other things being equal, that's a big factor with patient compliance, with side effects, with supportive care. So they haven't been compared head-to-head. But if we said, balancing everything else, that the SVRs between those two regimens look the same, they're not the same in practice. That's
Rita, would you or anybody else like to get off your chest a concern about having single-arm, uncontrolled trials as the basis for policy decision-making?
You are reading my mind because there are things, a lot of things that bother me about the trial. It's single label, it's single arm, it's open label, it has a surrogate outcome, which I understand that a lot of people have confidence in it, but I also think it's very hard to model somebody 40 years later and really know, are they getting a benefit or not? Because to me, I'm looking at something that says, even if I had hep C, the chance that I'm going to get hepatocellular carcinoma and die from it is 1 out of 100. Seems to me the chances of other things happening are a lot greater. And so I'm looking at adverse events, and again, I was trying to, in an open label trial, it bothers me, as I said, that there were 97 centers in this trial and with less than 600 patients. I mean, that, often is the characteristics of what we call a seeding trial, kind of a trial designed to get a lot of centers involved, but that's a very low enrollment per center, and it makes me wonder what happened there. So, yeah, I like randomized controlled trials with clinical outcomes and long follow-up, and I realize you can't do a 40-year follow-up, but this is a much shorter follow-up, and I always feel comfortable, particularly when we're talking about treating healthy people, that we have confidence in the data and that the data really are going to allow me to say confidently to my patient who feels perfectly well that I believe they should be screened and take a drug when they feel perfectly well now. And I'm just not sure, particularly in the, healthy people with no symptoms, no cirrhosis, no fibrosis, that I can conclude that based on these trials.
Rita, sorry.
You want to follow?
I would say, Rita, doesn't that apply, though, to what we're comparing it to? These drugs compared to the other protease inhibitors? So I think you're saying, right, since that the standard we're comparing them to is potentially flawed.
So I want to let the, especially those involved in clinical research, Rena and Todd perhaps, or Amandeep, your views of why the evidence is or isn't adequate. I mean, Rita has raised some concerns about the adequacy of the evidence. What is the view from the clinical research community on this? And obviously we have to note that the U.S. Preventive Services Task Force, even before these new drugs were approved, said the evidence was adequate to support screening. And we know that the FDA voted 15-0 in its advisory panels to support the regulatory approval of these drugs. So with those kind of as the kind of some backdrop, albeit with these concerns, help the panel understand the adequacy of the evidence for these new drugs.
So I'll take a stab at that. It was unique and surprising, I thought, that the FDA allowed an open-label, non-randomized trial. But I think historically we have a large amount of data that's very consistent across trials in terms of what the benchmark is. And it's such an objective response. I mean, it's a blood test response. It has nothing to do with symptoms or long-term outcomes either. The trials we've been used to seeing and doing for hepatitis C is simply eradicating a virus. And we know from larger, prior registration trials where the benchmark is set. And we rarely get head-to-head competitive trials, one protease versus another, or even one pegylated interferon versus another is what we were talking about for the last decade. But we know what a placebo will do, and it was felt that placebo-controlled trials were not appropriate for this population, and that the efficacy can be demonstrated with simply very high sustained virologic response rates, higher than we've seen historically. So I think the evidence for the new drugs is tremendous, and I have very little doubt in it. And I want to go back to the other part of your statements where, the patient who feels well, you'd be hesitant to screen them. It's kind of the tip of the iceberg phenomenon where there's a lot of disease percolating. This is usually a 30 to 50 year timeline for this disease to cause its problems, and very few people have symptoms to demarcate those timelines. 1 decade to the next. Occasionally, patients will come in and talk to me about fatigue and maybe some abdominal pain, but largely they don't feel it. But we try to get objective evidence by staging them historically with biopsies and now more commonly with blood assays or elastography. And we have been seeking out the patients with more advanced disease for treatment. And you could make an argument for those rare patients now that we see with F0. I don't see that very often. But for those F0 patients, perhaps justifying this treatment is harder. I can buy that. But if you focus on a group of patients who are sicker, these are patients that are much higher than a 1%. You can find a subset of patients, which is not small, 20 to 30% of our patients with hepatitis C will come to us with cirrhosis after a sufficient time course of infection or duration of infection. So I think what I do, and I think a lot of hepatologists do, is seek out the patients with more disease and target treatments there, and knowing that those outcomes, if we don't intervene, seeing the natural history of that is devastating. And now having newer drugs that can change that natural history and have been demonstrated to change the natural history, at least in the last decade of treatment efforts, it's really compelling.
Rena or Amandeep, would you like to comment?
I understand that.
Oh,
I
sorry.
just feel that it's a 12 or 24-week trial, so extrapolating the natural history, it takes a lot more conjecture.
I mean, I completely agree with your points, because I think definitely we don't have long-term information on these medications at all. But we cannot undermine the fact that these medications are very effective than what we had for all these years. So, and it's heartbreaking to see patients who are completely asymptomatic and have such advanced disease. So these medications definitely are more effective, easily tolerated, and we definitely need more long-term information on the outcomes.
I agree they're effective in decreasing SVR. I think what remains in my mind is how effective they are in decreasing the terrible clinical sequelae. I think we all agree those are terrible clinical sequelae, but how we change the course with this treatment is less established because, as I said, these are short-term drugs. I've seen lots of other drugs where you can decrease a viral load, decrease a serum marker, but we don't get the clinical outcome benefit that we would have expected.
Well, I think what we need to do is extrapolate on a newer generation of drugs that are reaching the same endpoint that we've been satisfied with for 20 years, and utilizing the natural history studies we have from the last 20 years, and extrapolating that the DAAs as a class will have the same positive benefit for patients over a longer timeline. They're not tracked in each individual trial, and they're not prospective, but we have observational studies clearly showing outcome improvements for patients with PEG and ribavirin as the old standard of care, with a much harder, we were less likely to get the outcome we wanted, much less likely, and a lot more side effects to get to that outcome. But if we were able to get to that outcome, the benefits improved over a 10-year timeline beyond that. So now we just have to have faith in the DAAs as a mechanism of action in eradicating virus, that it will bring the same benefits. And I believe that.
Rena?
I just wanted to add something about the idea of these not having a randomized control arm. Chronic hepatitis C has not had a big menu of options for treatment. They're really the only option until 3 years ago was interferon and ribavirin, with, say, 60% of all hepatitis C patients not being a candidate. So the vast majority of patients were not a candidate for pegylated interferon and ribavirin. Then when you introduce, at least if we're talking about the regimens without interferon now, you can't randomize those patients to pegylated interferon because they've not been candidates. And in terms of retreatment of patients, if you're going to randomize them back to the same treatment that they've already taken, we're not giving them any new option. If we're going to do a retreatment trial and randomize patients to be treated with the identical regimen, if they're not genotype 1, their likelihood of success is less than 15%, I would say, to be retreated with the identical regimen. So that's one of the issues. I also agree about the depth of the historical data. I think it's a different discussion about whether SVR is an adequate outcome to use, but that is the outcome that we have been relying on, and then looking at natural history studies of SVR versus no SVR.
I hope that was a helpful conversation. We're getting close to the point where we're going to ask you actually to have a seat back in the audience. You're also persuasive that we want to have a vote without having to look you in the eye. Before we do that, sometimes the panel likes to know where people think the evidence is strongest and where it's weakest. And we've sliced the patient population into these genotype and treatment naive and experienced, et cetera. Could you perhaps give the panel some guidance from your own personal perspective? Where is the evidence the strongest and the weakest that they will be taking votes on here for the new agents? Amandeep? Sorry, I'm focusing in on the clinical experts here, but go ahead.
So I'm a transplant hepatologist, so I think the evidence which is weakest at this point is the trials had shown who had cirrhotic patients in it had compensated cirrhotic patients, which were patients who had cirrhosis but doesn't have any complications from cirrhosis. So the evidence definitely, we need more evidence on decompensated cirrhotic patients, whether these medications can be given to all patients with cirrhosis, because at this point, the evidence is more in favor of advanced fibrosis and cirrhotics, but not decompensated patients.
And is there a genotypic or treatment experience naive population in which you think the evidence is the weakest and the strongest?
Genotype 2, strong evidence.
Strong, okay.
Genotype 1, better than what we have from other agents. And I think treatment experienced and relapsers or difficult to treat population, definitely more effective, but more information is needed.
Todd?
One other comment would be genotype 3. I think we still are struggling with compelling data. We have data to suggest our outcomes are similar to what we have with prior standard of care, but that to me is the weakest group. And then we have other needs, renal failure being one of them, and post-transplant care.
Okay, thank you. Rena?
So the areas I think that are specifically the weakest are sofosbuvir plus ribavirin without interferon in genotype 1 patients. There's very little evidence. It was a surprise to many people that was included in the FDA approval. So for both naive patients and experienced patients, and definitely weak in cirrhotic genotype 1 patients, then in the genotype 3 treatment experience group. And then in the Cosmos trial, the cimepivir-sofosbuvir combination, which is so promising, but we have so little data.
Let me ask if any...
I had
Amandeep, sure.
group to add. I think the information is weak in regards to patients who have been treated with tenofovir and boceprevir who had failed that combination. What to do with that group?
Any other questions about the evidence from the panel? You're all ready to vote. That's what we're going to do next. All right, then let me thank the roundtable. We'll have you back up after the votes. I think that was very useful for the panel. We'll just take literally just a minute while they get reseated. And now, again, you guys can start to look at we'll put them up here on the screen as well, but you have, and I believe the audience has copies of the voting questions too, right, Karen? Did the audience get copies of the voting questions?
Yes.
Good. And of the tables, right?
What's that?
The tables too?
Yes.
Good, okay. So for you in the audience, you'll be able to follow along much in the way that I hope that the panel can between the voting questions and the synopsis of our tables. All right.
Oh, sorry.
So I'm going to stand up here.
Stop pushing buttons. Right there. Okay. Okay.
All right. Let's see how we're doing.
Do you want to turn this back on? Do we know?
I think that helped, yeah. All right, I think we're going to work. Okay.
We're just going to do the first three slides up here, and then it's going to switch. So.
Then it's going to switch. Oh, that's right. Okay, and then I don't have control over it after that, right? Oh, terrible. All right. So this is, again, for half of the CTAF panel, this is their first experience voting. Each experience is somewhat unique, and this one will be no exception. So we're going to go through a practice slide using the voting technology that you've all been given. And just so you know, the format of the questions coming up are largely, again, in the structure of asking whether the evidence is adequate to demonstrate that a certain intervention, drug in this case, is equivalent or superior to another drug for patients with condition X. You'll be asked to vote yes or no. We do have variations on this theme, as you'll see. But let's just get our feet wet with, oh, I'm sorry. I also want to say that when we get to the value questions, and this is a bit of an evolution for the methodology that CTAF has used. We've been voting on value just recently, and we recognized that we thought it would be helpful to parse out some of the different categories within the larger categories of low value, reasonable and comparable value, or high value that we asked the panel to judge. And we had a call with the panel to kind of work through these different categories of how they would place the evidence on both effectiveness and cost. And so we'll again use these categories in the voting to try to capture your judgments and make it as transparent as we can for policymakers and others. So let's just make sure that the technology works. And now it goes over to the, all right, so the first voting question, you can't get wrong. We're going to make sure that it's working. What is your favorite national park? Acadia, Denali, Grand Canyon, Haleakala, Yosemite, or other? Now, the way these work, and I'm just going to revisit this, when we say time for your vote, you will have, is it 10 seconds or 20 seconds?
It's until we're done, and because there's so few voters,
Uh-huh.
the tally in the corner will show how many of 15 devices that are out.
Oh, okay. Oh, that's good. So we will know when everybody's voted. All right. And it will be the last number you push if you make, right. So if someone presses 4 and then says, oops, I really meant Yosemite, and presses 5, we're still going to get that 15? We're not going to get, okay, so it's the last number that was entered as we add it up. Okay, so let's just go ahead and test the technology. Everybody please enter in. That was very fast. All right. So what's the 0, 1? Now I'm trying to, okay. We have 14.
The number of people, so 10 people said Yosemite.
Right, but I thought we had 15 voters. We have 13 voters.
Okay, we need a couple more people.
So 2 more people were supposed to have voted who didn't, right? All right. So if we start over to test to make sure that everybody's is working, can they just push another number now? Well, if it's the last number they push, can't they just re-enter it? All right. We're going to do a randomized controlled trial of different voting technologies. And just so you know. We want to go back to the, you can't go back. Okay. All right. So if we don't get 15, all right, let's just wait till we get 15. All right, that's what we need to do. All right, so you passed that first question, the technology, so-so. All right, so now it's getting serious. I actually need to step out so I can see these questions better. Is there any way for you to sync it with this or not? Maybe I can do it though. Oh, I can do it. No, no, I'm fine. I can do it.
Steve?
Yes.
Can I get clarification?
Yes.
They're called questions, but they're not phrased as questions. It says stipulate that.
Right.
So should we turn that into a question? I mean,
Well, just for now, basically, the question is whether you agree with this stipulation. All right, so as we had looked at the voting questions before, the first question is to ask whether you agree with our stipulation. And we're looking, by the way, I meant to tee this all up, pages 3, 4, and 5 in your tables handout are the relevant tables. So on page 3, you see all the different studies on sivosbuvir and sameprovir related to genotype 1 treatment-naive patients. Page 4 are the results of the network meta-analysis. And page 5 is the summary table in which the key results from the network meta-analysis and where we had to, individual study information, is put in that kind of tabular format along with the modeled outcomes. All right. So hopefully that's helped. We're on page 3, 4, and 5, and the question is, do you agree to stipulate that cimeprevir plus PR and sofosbuvir plus PR are superior to telaprevir plus PR because there is adequate evidence of equal to better SVR and fewer side effects? We still have time. I mean, if people, we hope to get some of this out in the working lunch with the roundtable, but if people have a specific question or point that they want to make before we take this vote, now's the time. Otherwise, all right, just make sure you raise your hand or let me know otherwise. All right, let's go ahead and vote. Yes, you agree with the stipulation? No, you don't. Please vote. Somebody tell me when it says 15. We're there. All right, can you please display the results? All right, 14 yes and 1 no. We also, from time to time, and this is an ad hoc process, we explore the reasonings that individual members of the panel have for their votes. We hope that that's also helpful to decision makers. Would the person who voted no on this like to explain their reasoning? All right, make sure you hit your microphone so people can get it.
I was just unconvinced by the data. There were enough variables that
What was
bothered
it
me.
that was unconvincing? Is there a specific aspect about it?
I can't nail it to one thing, no.
Okay. All right, let's go forward to the next question. Because a majority of you voted that the evidence was adequate, that cimeprevir and sofosbuvir are both superior to telaprevir, we're going to have you vote on their value compared to telaprevir. So this first question, again, the same tables on the same pages, is that you've said yes. Now, what is the comparative value of cimeprevir plus PR versus telaprevir plus PR? So, Bob, for you who voted that the evidence was not adequate, you should abstain from this value question. So we should have a denominator of 14. So I'll give you some time again to look at the tables. And what we have up here, they couldn't display the tables? Okay, apologies. We couldn't use the table as a visual for the voting technology. But if you look at these different voting options, they relate to the relevant categories within each larger category that you could vote, that's your judgment of the evidence. So let me just read this. For lower value, you could either say it's low value because there's promising but inconclusive evidence of better outcomes and higher cost, or because there are better outcomes but at too high a cost. You could vote that it's reasonable or comparable value if you think that it's promising but inclusive evidence of better outcomes and roughly comparable cost, or because you think there are better outcomes at a reasonable higher cost. And you could decide that it's a high value if you think it's promising but inconclusive evidence of better outcomes and lower cost, better outcomes at either lower or comparable cost, or better outcomes and a slightly higher cost. Yes, Marge.
By outcomes, I assume you mean not just clinical effectiveness, but also harms.
Absolutely, thank you. So when we use the vernacular outcomes, we hope that you will include all of the outcomes on effectiveness and harms that you think should be included in a judgment of value. So that would obviously include SVR and side effects. It's a little bit more difficult to decide whether pill burden and other things are an important component of outcomes or not. And again, there's no right or wrong answer to that question. So it's a part of what you should decide as your own judgment. Let me go around because I know we have a couple of questions. That's fine. Meg?
Are we assuming treatment of all patients who are found to be hep C positive or only a subset based on clinical severity?
All patients. All patients who are eligible for these according to the FDA label. And these, again, are genotype 1. I shouldn't say all patients. We're talking specifically about genotype 1, treatment-naive, interferon-eligible patients. And again, that's the results that you see on page 5, laid out in your tables handout. Jerry, you had a question
Well,
or a comment?
on reasonable higher cost, it's being compared with tenofovir. So you have to-
Correct.
I guess that sort of assumes that that benchmark is a reasonable benchmark. I guess it comes back to Paul's question earlier.
That's correct. It's a tough question. We could have asked for you to vote, against the cost just of interferon and ribavirin. But in a sense, we did feel that we were guided more by the fact that there had been an explicit state-of-the-art state of care that included use of these agents, and we felt that insurers had made their decisions about funding those, so that was the more relevant benchmark for today's vote, at least. Sorry, yes, Michael.
Steve, to answer the question about whether this is all patients or an individual patient, maybe I misunderstood, because I was assuming what we're talking about is what you just said, that you get state-of-the-art medical care and then a decision to treat kind of question, not the public health question.
Sorry, the perspective that we want you to take on value is that of a Medicaid program. So when you think of treating patients within Medicaid and, trying to think of basically the budgetary issues of having a relatively fixed budget, however you think of Medicaid programs, we need to give you that perspective. So we can't tell you exactly what your budget is and how much you have and where the money would come from. It's very hard to bring all of the intangibles into this, but if you think of yourself as representing a public payer and your decision is about the comparative value of this for the patients that you serve, that's what I'd like you to try and do. Paul?
Maybe it would clarify, correct me if I'm wrong, but you say, here's a patient you're going to treat with tenofovir. Do you want to switch to the other drug or continue with tenofovir? That's the question we're being asked.
Mm-hmm. Well, it's not that really continuing. It's just
we're not considering people who you're not putting on tenofovir.
Correct.
All those are up. This person's going to get treated with one or the other.
Okay, life is an experiment, and this is a good example. So let's see if this helps us distinguish the voting for value. The votes will be from 1 to 9, and let's start the voting now. Wow, that was fast. All right, so let's see, and I'm hoping that we can keep these categories up when we see the results. Oh, fantastic. Okay. So let's just reflect. Shoot, I can't see this very well. So I'm going to step around. There we go. Thanks. All right. So what we had was 8 of the panel voting that it was low value because they judged there were better outcomes at too high a cost. 3 judged that it was reasonable value because better outcomes at a reasonable higher cost. And 3 thought there were high value, 1 because better outcomes at lower or comparable cost, and 1 because better outcomes in slightly higher cost. So this is, I think, capturing in a very interesting way at least, some of the differences in the judgments being made about the relative cost. If I'm right, everybody said that there were better outcomes, right? That was not what was at issue. So let's just explore briefly. Would one of the 3 people who said it was high value say a little bit more about your rationale, and then we might try to ask someone who said it was low value, and it's all about the relative cost. Yes, Paul.
Yeah, I was one of the 8s, and I accepted the model in Table 23, which said that the drug costs are cheaper. Given that the drug costs are cheaper and that the 20-year offset even lowers the cost more, it seemed like it was dominant, again, if you accept the model.
Now you're talking about the cost, you're talking about cimeprevir?
I'm looking at the modeled one-year drug costs in Table 23 of cimeprevir being less than tenofovir. At 1 year, yeah. And then, obviously, it seems that then there's a lot more savings if you do a longer time horizon.
Okay. How about somebody who judged that it was high value? Better outcomes, but at either lower or comparable cost or a slightly higher cost? Would one of those three people like to describe their reasoning? No, I'm sorry, I thought you were one of the 8. Yes, okay, I'm sorry. I thought you said you were one of the 8. I thought you were answering. Okay, so let me turn it over to someone who was in the one of the 8 who said that it was low value. Too high a cost. Rita?
I guess it's a little tricky because clearly initially it's higher cost and then the rest is all the modeling and the comparison, which as Paul pointed out earlier, it assumed that we were just treating or comparing it to telaprevir, but I think the difference is there will be a lot more people treated with a drug that doesn't have all the side effects, and therefore I kind of included that in the calculation, and then it's going to be higher cost with less promising outcomes. Because just the uncomfortableness of the treatment limits the telaprevir.
Okay,
Less
so you were thinking
PR.
about the real-world impact on budgets because of the likely higher use of cimeprevir compared to telaprevir. Okay. Was anybody else's reasoning for their judgment of it being low value distinctly different than that, such that they'd like to share it?
My feeling about the side effect difference between the telaprevir and cimeprevir is that a lot of the side effect issues are related to the interferon. And I think that probably swamps which of the DAAs you use. And so to me, it seemed like you would still see a number of people with incomplete treatment, or, and that would really diminish the value you have been paying for something that would not, when patients weren't fully treated. So that's how I looked at it.
Okay, Doug, did you want to add something?
I'm just impressed by the number of events averted over 20 years being 19. So it's a huge upfront cost for purported benefits over the next 20 years. And I would argue that's low value.
All right. Okay, good. Let's move on to the next voting question. We have about 19,000 of them. So we should keep going. And I keep thinking I have control, and I really don't. So the next question is, can you go to the next slide? Oh, I'm sorry. We have another value question. That's right. Sorry, because we now are going to talk about the comparative value of sivosbuvir plus PR versus telaprevir plus PR. Okay, you know which tables we're looking at. I'll give you a second to look at the numbers again. Categories are exactly the same. Does anybody feel unready to vote? Okay, let's open up the voting. Again, we should have 14. There we go. Okay, you can show us the results. All right, for the comparative value of sivosbuvir versus telaprevir, we have very, very similar results. Is there anybody whose vote changed or was made on some significantly different basis from the earlier votes that would want to say anything? There may not be, but anything very different? Okay. Good. Now we can go on to the next comparison. And I think we start with another stipulation. Okay, so now we've got these two new drugs, sivosbuvir and cimeprevir, both of which you've said are, the majority of you have said are superior to telaprevir. So we're going to stipulate that the evidence is inadequate to distinguish between the clinical effectiveness of these two drugs. And I know we discussed this a fair amount with the round table. Anybody want to ask any questions? And we're on the same tables, pages 3, 4, and 5. Yes, Alex. Thank you. That's something we should work on, but the terminology should remain the same, and since it hasn't, I need to clarify that we do mean that we are looking at both harms as well as benefits. Thanks for that question. Does anybody feel unready to vote? All right, let's open up the voting. There should be 15, sorry. You're back in the game, Bob. Okay, thank you. This is working well now. Let's see the results. All right, 13-2, agreeing with the stipulation that the evidence is inadequate to distinguish. So one of the two people, perhaps, who thought that it wasn't adequate, would you like to tell us why?
Yeah, I misvoted.
You misvoted. There you go. So would you like the vote to read 14-1? Yes. All right. Does the lone wolf want to describe their thinking? Again, if... Really? All right. No, that's okay. It's good to recognize that. So there's no peer pressure whatsoever. Each panel member is an autonomous being. All right, we have 15-0 then. That stipulation is agreed to. So let's go to the next question. Believe it or not, we're getting through the stipulations, and there'll be a lot more real votes soon. Okay, now you actually have to look at one additional page of information in your table handout. Page 6 has the information from the Cosmos study. Because now we're talking about genotype 1 treatment-naive interferon-ineligible patients. And we get to
Steve,
page...
We're
Yes,
talking about all comers again?
correct.
Perfectly healthy people?
Pardon me?
Everyone? Healthy?
Everyone who is genotype 1 treatment-naive interferon-ineligible. So we're going to stipulate... Right. 6, the reason that 6 has the data from the single study of treatment, well, Cosmos was treatment experienced, but the reason that it's important is because it's used to estimate the effectiveness among treatment-naive patients. And that's indicated, if you see on page 5. Sorry, I guess actually that page 6 is relevant more for the next vote coming up on sivosbuvir plus simepravir. Apologies, you don't really need page 6 for this vote. Okay, so just to clarify again, we're voting among genotype 1 treatment-naive interferon-ineligible patients on sivosbuvir plus R is superior to no treatment. Because remember, these patients cannot, there's no other treatment for them FDA approved. Okay, is everybody ready to vote? Kim is really unhappy down there. Ready but unhappy. Okay, let's go ahead and vote on this stipulation. We need 2 more. Okay. We can see the results. 12-3. All right, so that meant 3 people thought that the evidence was not adequate to stipulate that sivosbuvir is superior to no treatment. Would anybody like to, from that group of 3, describe why they thought that was the case? Bob?
I'm probably wrong, but at least I'm consistently wrong. There are no studies with SV12 data in treatment-naive patients not eligible for interferon. The data was inferred.
Actually, for this one, sivosbuvir plus R, there are pooled data from two small studies, Photon 1 and Quantum. You see that cross? So there were data directly. There were no controlled trials, but there were two studies in which patients who were interferon ineligible were treated just with sivosbuvir. Okay, why don't we keep going? Because now we're going to probably have a value vote on that. All right, so we're looking at that same single comparison of sivosbuvir plus R versus no treatment. And here are the categories for low value, reasonable value, or high value, the same as you've seen. Okay. I'm guessing we're ready to, is anybody not ready to vote? Okay, Marge, we'll wait one sec. We ready? All right, let's go ahead and vote on the value. There should be, whoops, somebody remind me, how many people? Is it 12? Okay, there should be 12 of you voting on this one. Wow, we got that quickly. All right, we can see the results. Survey said. All right, so we have 9 voting low value, 2 people voting reasonable value, and 1 person voting high value. Again, we've got a similar spread to the value questions before. Does anybody feel like they have a distinctly different perspective on the reason for their vote that they'd like to share? You're new, Alex. Well, what would you like to change from what to what? You want to, okay, so you want to go from high value to low value. All right, okay, so the votes then would be 2, 8, 2, and 0 in the high value. All right, let's keep going. All right, not a stipulation. And I think let me just describe why this one is not a stipulation. This is an off-label treatment, and the evidence come from a single study, the Cosmos study. And this is the one for which if you want to see the actual data from Cosmos, you do have to go to page 6. This does not come from the network meta-analysis. So there are 4 arms to the Cosmos study. You can see the results for each of them. You can see the number of patients in each of them. Now, again, the first comparison we're going to ask you to make is about its effectiveness. Sorry, superior. The outcomes are superior to no treatment. These are patients in this group for whom there have not been any treatments until very recently.
And this is for all comers.
This is for all genotype 1 treatment-naive interferon ineligible patients again. All right. So it should be, right, the reason that, so the Cosmos, let me just describe again what happened. The Cosmos data, which were not among treatment-naive patients, they were among treatment-experienced patients, and usually they have worse outcomes in terms of SVR. So whether we were conservative or liberal, we just took the same 90% SVR rate that was achieved among treatment-experienced patients and brought it over as an assumption into the treatment of treatment-naive patients. That would mean, to be honest, that most clinicians would say, if anything, it's going to be higher than you would find in treatment-experienced patients. But again, we have one small study among treatment-experienced patients on which to judge all of this. And this is an FDA off-label. This is an important vote for the panel, I'll highlight, because this is a regimen that's being discussed a lot in the clinical community. It is off-label, but there are now some treatment results. Obviously, it involves the taking of 2 expensive pills for a patient group that has not had good treatments until now.
And Steve, we're talking about superior for clinical outcomes in this group of all comers, not necessarily SVR load alone, but overall clinical outcomes.
True, yes. Okay. Still missing one. Did people start to vote while I was talking? That's terrible. Good, we're still missing 1 vote. All right, now we have it. All right, thanks. Interesting. All right. Now we get to have a food fight right here in the middle. All right, who thinks that the evidence is adequate to demonstrate that sivosbuvir plus sameprovir is superior to no treatment? Who does? Dan, please tell us why.
Because I heard our chairman in the background trying to massage our vote by telling us that it should be less effective, and it turns out to be more effective in a treatment experience group. So I was willing to make that leap of faith.
Another voice from the yes camp before we go to the no camp. Jeff?
So, yeah, I mean, it's only a single uncontrolled trial, but to me, this is sort of like the randomized controlled trial for parachutes. There never has been one, but I don't think there will be, because this is already a group with no treatment.
All right. Who did not think the evidence is adequate to demonstrate that this is superior to no treatment? Alex. Don't tell me you want to change your vote.
I was concerned about the small sample size, incredibly small sample size, and lack of long-term outcomes.
Any other voices around that judgment? Yes, Christine.
I also was concerned about that, and I want to take a little bit of pushback on the parachute example. A fall from an airplane is a fairly rapid event. There's definitely time to do something with a cohort of patients that you're not treating, given the time course of the complications we're talking about. It doesn't mean you're never going to treat them. It just means you're not going to treat them now. So I think that, and also given the cost of these medications, to say that, oh, it would be too expensive, or, oh, we can't have a placebo group, are both spurious arguments.
I think these are valuable perspectives to gather along with the votes. I definitely think so. Any other comments people would like to make about this vote? We are going to move to the value voting next, unless I'm wrong. I think the next vote should be a value question. Okay, well, now we're going to vote on the value of sivosbuvir plus sameprovir versus no treatment. I know it seems a little bit odd to have those of you who voted that the evidence is not adequate to not have any vote on value, but it's something we can revisit. But we've made a long-standing decision that if you feel that the evidence isn't even adequate to say that it's better, then you would, in a sense, automatically call it low value. So we'll have to kind of, well, not automatically, but what we're looking for is if the evidence is adequate, at what value is this treatment viewed? Pardon me? True. So we're going to take the 8 people who voted that the evidence was adequate and ask you to vote on its value. With those same categories. Is anybody unready to vote among the 8? Oh, they're already up. Sorry. Let's see them. You guys are way ahead of me. Oh, we have an extra vote. Is that okay? And we'll have to say, what's the one vote that technically? All right, so it should be 3-3-2. All right, so There are 3 votes for promising but inconclusive evidence of better outcomes and higher cost, 3 votes, better outcomes, too high a cost, and 2 votes, better outcomes, reasonable, higher cost. Okay. I think we can keep going without delving into the comments on this particular vote. So let's do so. Let's go to the next voting question. That's another, is the evidence adequate? Okay, so now we've got 2 different options for genotype 1 treatment-naive, interferon-ineligible patients that you've, at least in one case by 8 to 7, said that the evidence was adequate to say it was better than no treatment. Now we're going to compare them to themselves. Is the evidence adequate to demonstrate that sivosbuvir plus cimeprevir plus ribavirin is equivalent or superior to sivosbuvir plus ribavirin? These 2 rows are right next to each other. On the table on page 5 at the bottom. Well, no, in terms of the page at the bottom of, it should be page 5 on my tables, right? Yes, the comparison of the 2 is easiest if you look at the 2 rows at the bottom of the table on page 5. Yes, sure. In terms of, again, the whole package. Not cost, correct. Right, benefits and harms. Okay, so this is a question about adequate evidence to demonstrate equivalence or superiority. Because you see the numbers there in the table, 900 and 720, and of course there are other things to consider too. But the question is whether evidence is adequate to demonstrate the equivalence or superiority of the 2 drug versus the 1 drug. All right, why don't we go ahead and vote? And we have 12, we should have 3 more. Someone holding out, or does someone, there we go. All right. All right, 9 said the evidence was not adequate, and 6 said the evidence was adequate. Given the number of votes, I'm going to try to be a little bit pickier about which ones we debrief on a little bit more, but if we come to one where someone is really burning to say something, please raise your hand and let me know. But I think we're going to go ahead and vote on the value on this one. No, we're not, because there was no majority that the evidence was adequate, so we are not going to vote on the value of cimeprevir plus sivosbuvir versus sivosbuvir alone. Next. We could skip that one. Yep. Okay, almost done with genotype 1. Almost. All right, so we have another stipulation. Again, now we're moving on to pages 6, 7, and 8 in your table's handout. Page 6 has all of the studies with information relevant for treatment-experienced patients. And by the way, for those of you who have it in color, which, is that all of you? Yes, the yellow, the reason that the yellow, there's some yellow highlights, those are the regimens that were part of the FDA approval for the indication. So that's why those are highlighted in case you were wondering. So that's page 6. Page 7 are the results from the network meta-analysis. Where the results do not come from the network meta-analysis, you will see the specific study they are drawn from. And then page 8 is the page with the table that, in a sense, pulls it all together. Now, as we take certain votes, I will draw your attention on page 8 to, again, the sources of the data. If you're on that page, you'll see the asterisk following some of the drug regimens. That means that the results for that one come from the network meta-analysis that Jeff did. And then you'll see the different symbols will lead you to footnotes that tell you what was the source of the estimate for SVR for this population. Some come from specific studies. Some actually are extrapolated from the results of single studies. And in one case, there's actually no available data, and we did it ourselves. We extrapolated downwards, and I'll get there when we talk about that. So, yes. I'm sorry, can you use your microphone? I can't hear you.
Can you just clarify on page 7 that TVR is the same as TEL? That's what you're trying to say?
Oh, I'm sorry. Yes, TVR is telaprevir. Apologies. Oh, okay. If there's somebody who knows how to fix the screen in the front here. Do you guys know how to fix the screen? The monitor in the front is on the fritz, if you can fix it, if there's a way. That's going to be tough. Let's see if he can fix it real quickly. Did it just happen all of a sudden, or is it? Yeah. Ah, thank you. High value. All right. So here, genotype 1, treatment naive. Oh gosh, move on, Steve. Treatment 1, treatment experienced, interferon eligible, pages 6, 7, and 8. We thought we would stipulate that cimeprevir plus PR is superior to telaprevir plus PR because of adequate evidence of equivalent SVR and fewer side effects. So this is the explicit statement that it's not just SVR, we're also looking at the issues around side effects. People ready to vote? Looks like you already have, if you're comfortable. That's good. We're up to 13. Just need 2 more people. All right, thank you. All right, 12 people agreed. 3 people did not. Just again, in this case, if anybody would like to comment from the group that thought that the evidence was not adequate, would they like to explain their reasoning? That's okay. Okay, can you just hit, so you want to change, okay, so one of the no votes should be a yes vote. Okay, so it's 13-2. All right, why don't we keep going? We're going to maximize our chance with the round table if we can continue to plow through these. Time to do a value question, since the majority said that the evidence was adequate to say that it's superior. So what is the comparative value of cimeprevir plus PR versus telaprevir plus PR for these patients? You're looking at the top 2 rows of that table on page 8. Actually, this is a good system. People can vote when they're ready, and we just sum it up. So please go ahead and vote if you're ready. Yes. Sure, Meg.
I'm not sure why the total estimated cost offsets are 0 for the SMV plus PR, and also the liver events averted. Why are those numbers 0 on page 8, table 24? Am I the only one wondering that?
Those, right. It's a delta from the baseline. That's why, so the telaprevir plus PR line, the reason it's showing dashes is because it's the baseline.
So it's incremental.
And these are all incremental. Estimated from the model. All right, so let's see, we should have 13 votes for the value. All right, we're still reading 11. Are 2 people still working on it? I just want to make sure the technologies work. Oh, okay, 12. 1 person, I think, we're still waiting. There we go. All right, we can look at the results. Oh, wow, it's still an interesting spread. So we have six people saying that it's low value, split between those who thought it was promising but inconclusive and higher cost, and better outcomes and too high a cost. Looks like 5 people thought it was reasonable value, and 2 people thought it was high value. So this is interesting to get this kind of spread. We haven't seen this much spread on many of our value questions over time. And it usually, again, it reflects underlying judgments, obviously, about the strength of evidence and about the costs and other issues. So let's just take a sec here. Would somebody who voted that it was high value explain your thinking? 1 of 2 people? Sure. Marge?
Unless I totally messed this up. Yeah, I didn't see the cost difference as being so dramatic, but obviously the better outcomes because of the fewer side effects. And that convinced me it was higher value.
Okay. So you thought it was better outcomes and slightly higher cost?
Yeah.
Okay. And somebody who voted either 1 or 2? Anybody?
It's based on anemia. It looks like the difference is we're voting on anemia, and it's actually over $100 million in the first year of cost. So that seems like a very expensive alternative to anemia.
Well, the difference between the two, right? That's what you're looking at? The difference between the two in total drug cost is about $12 million per 1,000 patients. Just want to make sure you were looking at that correctly.
We used to think it was expensive to spend $12,000 for a drug per year. I guess that's old news, huh?
Yeah, that's part of the difficulty in voting with telaprevir as your baseline, because it's already very expensive, and actually the price has been raised within recent months. So it's both a moving baseline and a tricky baseline with which to judge value. I agree. Okay, let's keep going. The next question, again, about interferon eligible. We're looking at sivosbuvir plus PR. That's the next row down. This is the one that is part of the FDA label based on data from the study Neutrino. Jeff, why don't you just describe briefly again how the FDA, how it used the data from Neutrino to fill in this slot on the table?
Thanks, Steve. So Neutrino was in treatment-naive patients. What they did was they took a group of people with poor prognostic indicators for response to therapy. They had high viral loads. They had a non-favorable IL-28 genotype. And I think they had higher fibrosis scores. So they had to have all 3 of those, and they looked at the response rate. There was a total of 40 or 50 patients who met that, and the SVR was 71% out of the 47 patients, I think.
All right, yes, Kimberly.
Can I just clarify that the way this question's written, it's not equivalent, it's superior. We're asking if it is superior.
Yes. The other difference to note, and Jeff, you make sure this isn't a typo on this table, I don't think it is, but this is a difference of using interferon as part of this regimen for 12 weeks with sivosbuvir plus PR, as opposed to using it for 24 weeks with telaprevir plus PR. Correct? And that was the main reason that the the vote was about superiority, because the numbers on SVR are very close, and the issue is more around whether there's adequate evidence on that, and with the benefit of much less time with interferon. Okay, why don't we go ahead and vote? Sivosbuvir plus PR superior to telaprevir plus PR. Should have 15. Almost there. Okay, thank you. We can see the results. Okay, 11-4. All right, I think we're going to want to keep going, because now we're going to do a value. You've looked at the clinical evidence. Now you're going to vote on the value for that. Sivosbuvir plus PR versus telaprevir plus PR. All right, let's go ahead and vote. All right, there should be 11 votes on the value side. Do? Good, okay. All right, 7 said it was low value, 2 reasonable, and 2 high. All right, let's keep going. The next topic is another one about clinical effectiveness outcomes. Now we're looking at the results for sivosbuvir plus cimeprevir plus ribavirin versus telaprevir plus interferon plus ribavirin. So these are the results that come from the COSMOS study. All right. Any questions? If there are any questions about the data, I know we've covered a lot. You guys are doing great with these votes. I know there are a lot of them. So we should have 15 votes on this question when you're ready. They're there? Yep, we can see the results. Okay. 10 yes, 5 no. I'm going to keep going unless people at this point have specific issues. We're going to be closing out genotype 1 pretty soon. All right, now we need to ask a value question. This one is about sivosbuvir plus cimeprevir. So you've just looked at the clinical information. You know the row to look at for the financial information. Okay, so we can go ahead and vote. I always forget how many people said yes. 10? All right, there should be 10 value votes. One more. There we go. All right. And here we have 6 as low value and 4 as reasonable value. Are you guys finding the value categories helpful to your progress through these? Good. We'll debrief on them later too. Okay, let's keep going. take a breath. We're just about to switch, in a sense, our subtype, our subgroup, I should say, from genotype 1, treatment experienced, to interferon eligible. Whoops, no, not that one, ineligible. Here we've got two options that are going to be compared to no treatment. The first, sofosbuvir plus ribavirin, again, you'll notice the symbol there says no available data. We pulled data from Photon 1 and Quantum, which are treatment-naive patients, and we adjusted the results downward based on the decrement from treatment-naive to treatment-experienced that's seen with sofosbuvir plus PR. This is on page 8. So if you're looking at across the row there at the SVR, that number 610, that's basically taking the results from 2 studies in treatment-naive patients and decreasing them proportionately. Sorry, they're still ineligible. Sorry, sorry, they're from treatment-naive patients, and decreasing them relatively in this treatment experienced. Oh, it does? Is this? Oh, did I? I skipped. I'm sorry. I skipped one. Shoot. So we're still back with interferon eligible. Sorry about that. There really are a lot of these votes. Okay, sorry. So we're still on that same interferon eligible. Now we're looking at sofosbuvir plus sameprovir. Okay, the single study Cosmos. This is an off-label treatment. You've seen it before. And we're comparing it to sameprovir plus PR. Now you may ask why we're comparing it to sameprovir. That's the one that we thought had, in some sense, the strongest data for this indication, and we said that sameprovir and sofosbuvir are essentially equivalent in terms of the SVR. So we're asking you to compare it to sameprovir. All right, we can go ahead and vote on the clinical effectiveness of this regimen. Good, okay, we can see the results. Ooh, 8-7. All right, so very closely, and this is almost identical, if my memory is right, the same 8-7 vote that we had on sofosbuvir plus sameprovir for treatment naive patients. All right, so I think we explored the reasons behind people's thoughts on the adequacy of the evidence. If anybody wants to say anything distinctly different, let me know. Okay, we can continue on to where I thought we were. Oh, no, we have to do value. Okay. So now, again, we're looking at sofosbuvir plus sameprovir, that same row you were just looking at. We're comparing it to sameprovir alone, and we're asking you what is the comparative value. Very good at this so far. You can go ahead and vote when you're ready. And let's see. We should have 8, and we do. 5 are low value, and 3 are reasonable value. Okay, very good. All right, I'm trying to see if we can focus on any subset of these. But if we go to the next question, we are into the last bucket here. We have sofosbuvir, right. I'm trying to think how we can speed this up. But I guess we should just keep going. So for this one, we are now looking at the lower half of that table on page 8. We're looking at the genotype 1, treatment-experienced, interferon-ineligible patients. So this is that long rambling statement I made about where the data came for the sivosbuvir plus ribavirin arm. And you see the same data from the Cosmos study. All right, so the first question is going to be, is the evidence adequate to demonstrate that sivosbuvir plus R is superior to no treatment? Does anybody have any further questions about the sources of the data? All right, so there should be 15 votes when you're ready. Okay. All right. 10 said the evidence was adequate, and 5 that it was not, compared to no treatment. We are going to ask you to vote on the value for the 10 of you who said the evidence was adequate. The value versus no treatment. You may make your vote as soon as you're ready, because you're now used to this process. Should be 2 more. Okay, we're ready? All right, 8 low value, 3 reasonable value. Excellent, let's keep going. The next one is sivosbuvir plus sameprovir plus R plus ribavirin versus no treatment. Data from the Cosmos study. All 15 of you can vote when you're ready. Okay, we're ready. Okay, 11-4. The evidence is adequate. So yes, you guessed it, we're going to vote on the value of sivosbuvir plus sameprovir versus no treatment. And then we will do a quick one on sivosbuvir plus sameprovir versus sivosbuvir alone. So this one, sivosbuvir plus sameprovir versus no treatment, the value. And sorry, was it 11 on this one?
Yes.
11. One more. There we go. Okay. All right. 6 low value, 3 reasonable, and 2 high value. We haven't had 2 in that not better outcomes, slightly higher cost. Interesting. Since we're comparing it to no treatment, which doesn't cost anything, and the 1-year cost on this is $154,000. Does anybody want to explain that rationale? Paul.
Well, that wasn't me, but I will. But you're missing a category, right? You could have such great outcomes that even though it's very expensive, it's high value, and you don't really have a number, I think, to fit that category.
I guess so.
So
we played around with it.
That's
We
what they
thought,
think.
yes. I mean, I think we assumed that people would call that better outcomes, reasonable higher cost. 3 people put it there, but it is hard sometimes. You're right with the wording. Okay. We have one last value question on the table. The next question, don't we? Efficacy first. But they were both, all right. I'm grumbling about my own questions. There are too many of them. All right, so now again, is the evidence adequate to demonstrate that sivosbuvir plus sameprovir is superior to sivosbuvir plus ribavirin alone? Looking at the same rows, the same tables. All right. You may vote when ready. 15, we're almost already there. While we're waiting for two people, for one person, I will thank the panel in advance for all of these votes. This is what pharmacy and therapeutics committees will be sitting down to do around the country. For each indication, they will be making judgments about these drugs and about the adequacy of evidence. So what you're doing is hard, and I'll even say it, tedious, but it will be helpful as guidance for people. So one person was listening to me instead of finishing their vote, but we should almost be there. Can everybody press your button one more time? It's possible that somebody's vote didn't get registered. There we go. Thank you. Okay. No. All right. You just saved yourself a value vote. You're starting to understand how this works. So we will not take a vote on the value of Cimeprevir plus Sivosbuvir versus Sivosbuvir plus Ribavirin, and we will move on to genotype 2. It's all downhill from here. And I'm not kidding. There are many fewer treatment options for these patients. So we will now shift to different tables. You may now go to pages 9, 10, 11, and 12. Page 9 has the specific studies with the findings in each arm. Page 10 has the table that you're now very familiar with for treatment naive. And pages 11 and 12 have the treatment experienced information. So we'll start with treatment naive. Pages 9 and 10 are your focus. And the first question is, here for patients with genotype 2 who are treatment naive, we have the baseline. Remember, Telaprevir was not indicated for these patients, was not, basically it wasn't developed to be for these patients. So the baseline existing standard of care has been interferon plus ribavirin. So the comparison here is Sivosbuvir plus R versus interferon and ribavirin. And we're going to stipulate, that's right, because looking at the information, we decided that it seemed reasonable to ask you to stipulate that the evidence was adequate to say that it is superior, given... am I on the wrong page here? I apologize. Okay, let me read the question from here. We're looking for both treatment naive and treatment experienced. That's why it's important to look at both pages, all these pages. So we're going to ask you a single stipulation that actually kind of lumps two of these together, because if you take a look at the rows, take a look at Sivosbuvir plus R versus interferon and R for the interferon eligible patients, and Sivosbuvir plus R is superior to no treatment for those who were ineligible to have interferon. We thought that the two were reasonable to lump together in a single stipulation. Does anybody have any questions about the data? Jeff?
I'm still confused about the question, even though I'm not voting. Did you really mean treatment naive, both interferon eligible or ineligible?
Yes.
And you do have treatment naive or treatment experienced.
Oh, the green is wrong. The question is correct, sorry. Thanks, Jeff. No, this is not among both treatment naive and treatment experienced. It's among treatment naive patients, both interferon eligible and ineligible. Good catch. I've had nightmares about this. I don't know if when you guys were trying to read this, every once in a while you think you actually have all these categories down and then they just bite you. One big stipulation for everything? But treatment experienced genotype 2. No, you're right. We were. All right. well, I should review my own slides beforehand. So basically, we are trying to get by without having multiple votes between all of these different treatment-naive and treatment-experienced groups. If you look at the rows having to do with sivosbuvir plus R, for the interferon eligible or interferon ineligible, the relative advantage in SVR versus existing care was at a very high level. And we tried to give you the information about the sources of the information. But Jeff knows this better than I, but basically the original idea for sivosbuvir, it was in many ways kind of first thought of as a treatment for genotype 2 and genotype 3. And it's, yeah, the early trials started to make it, right, and there were more randomized trials in this group. All right, so I think we ought to go ahead and vote on the stipulation. Go ahead and vote up to 15. We already have it. Okay. All right, 14-1. Thank you. Now we can vote on the value. Now again, you'll have to take a look at both of the tables, probably page 10 and page 12, because we're trying to ask a single question for both treatment-naive and treatment-experienced patients. What is the comparative value of sivosbuvir plus ribavirin versus interferon and ribavirin? I'll give you a second because I know you're going to be looking at two different tables here. Okay, but when you're ready, you can go ahead and vote. Should be 14 of you. Are we there? Almost. Good. All right, six low value and 8 reasonable value. Everybody's saying better outcomes, and just the question is whether the cost is either too high or reasonable. All right, let's keep going because I know we're going to come back to some of these value judgments about the costs with the round table as well. The next question. Okay. Yeah, we should take a vote, I guess, because remember, we just compared sivosbuvir plus R versus interferon plus R, and now what's the value of it versus no treatment for the interferon ineligible patients? Okay, and we should have how many value votes? Okay. Good, almost there. Thank you. We have the results. I bet it's going to look very similar. 3 low value and 11 reasonable value. Okay, so the shift there from low value to reasonable value actually probably makes sense. I can see the clinical rationale versus, in the judgment of whether the higher cost, it is a higher cost, but whether that higher cost is reasonable, I think is judged versus the relative outcomes for patients who did not have any clinical options. Okay, one last set of a couple of questions for genotype 3. Pages 13, 14, 15, and 16. These will look very similar to the ones you just looked at for genotype 2. And so I'll ask the same kind of, combined stipulation question. Because we're going to be looking at whether sivosbuvir plus R is superior to PR for the interferon eligible patients, and sivosbuvir plus R alone is superior to no treatment for interferon-ineligible patients among both naive and experienced. Now, I should probably just reflect again on the source of the information that you're seeing on page, let's see. Yep, so if we're looking at page 14, the sivosbuvir plus R, right, that comes from a single study positron, as opposed to from the meta-analysis. The other, sorry, there was no meta-analysis here anyway, and all of the different studies that we have here are from individual studies, the data here. Okay. All right, let's go ahead and do the stipulation. Yes or no? Agree that it's superior for interferon-eligible patients and superior to no treatment for interferon-ineligible patients? Both? All right, we can see the results. I'm guessing 14 to 1 or 15 to nothing, okay? So then we will move on to the value. First, first we're looking at it versus PR for the interferon-eligible patients, and then you will get one last value question after this one. So all 15 of you can vote on this one. Waiting for two more. Everybody, if you want, you can all right, got one more there. Everybody press your button one more time, because I bet, yep, okay. Thank you, and 7 low value and 8 reasonable value. We've seen that spread before throughout these. It's, I think, the difference in the way that you guys are judging the relative cost, and there's been a spread there. So the last value question, I thought you were going to applaud when I said that. The last value question is the comparative value of sivosbuvir versus no treatment for the interferon-ineligible patients, genotype 3. How many? Is it 15? Oh, it's 15. Yep, so all 15. Okay. Final results. Okay. 7 low value and 8 reasonable value. All right. So unless I'm mistaken, that completes our voting on both the comparative clinical effectiveness and the comparative value of these agents. That was very well done. Very well done. There's the clapping I knew would come. All right. So now we actually get to talk about the real-world ramifications of your judgments about the value and the effectiveness of these drugs. We are going to take a literally 3-minute break to let the roundtable come back up, to let the panel quickly skip out if they need to, and we will reconvene at 2:40 to start the policy roundtable. Thanks.